Hello friends, I am Dr. Saurabh Srivastava, reader in the Department of Oral Medicine and Radiology, BBD College of Dental Sciences, BBD University, Lucknow. Today we will be taking up the topic of bleeding and clotting disorders, the second part of which shows the oral manifestations. In the first part, we had discussed about the various phases of the coagulation cascade, namely the vascular phase, platelet phase, coagulation phase, and the peptidolytic phase, and the various tests which we can advise are various tests. What is the significance, what do they show, and the various tests for the vascular phase and the platelet phase, various symptoms for the which are characteristic for the coagulation phase of bleeding disorder. All these things have been discussed in the part 1 of this lecture. In the part 2, we'll be seeing about the oral findings. Now, when we talk about the oral findings, we will see basically all the parts of the oral mucosa. Whether we start from the lips, we see the tongues, gingiva, we see the tongue, we see the mucosa of the palate, the buccal mucosa, or even in the posterior part of the oral mucosa near the facial pillars. If we are able to see any area of erythema, if we are able to see any area of spontaneous bleeding, if we are able to see any area which shows bluish, reddish, or blackish, slightly blackish, pigmented area, which according to the history of the patient will be present for some time, and the patient will come to know that there is a certain abnormal area in the oral mucosa which the patient will tell us if we inquire about it in the history part. So it can be seen as a frank bleeding area, as a submucosal bleeding area. The color may vary from reddish to bluish to blackish, even in some cases the crustaceans is formed. Petechial hemorrhages can also be seen on the soft palate or the junction of the soft and the hard palate many times in bleeding disorders. And erythematous patches can also be seen on the oral mucosa. In frank bleeding areas will give clots in the oral cavity, as well as the foul smell will be there. Patient will not be able to eat or drink anything, and there will be spontaneous bleeding from a certain aspect of the oral mucosa, from the gingiva or any ulcerative lesion which is bleeding spontaneously. If we see over the skin in cases of mostly traumatic injuries to the facial bones, where bleeding occurs under the skin, subcutaneous bleeding occurs, there we can see ecchymosis, which is usually an irregular area of dark pigmentation, most commonly formed because of the pooling of the blood, and that has caused this pigmentation. It will be seen at the site of injury mostly, and we can easily identify it with a history of trauma in such cases. So what do we do for dental management in such cases where there are certain bleeding tendencies? So it all depends upon the type and invasiveness of the procedure. First of all, we have to determine what type of procedure we are going to perform on such patients. Second is the type and severity of the bleeding disorder. So if there is any bleeding disorder which is very, very severe, then we have to arrange certain things in the pre-procedural phase so that we can perform the procedure. We'll see later on what's going to be done in the pre-procedural phases. Then when significant bleeding is expected, we have to make a call so that pre-operatively we have to restore the hemostatic system to an acceptable range or a desirable range by supporting the coagulation with adjuncts or the local measures. So we have to make the coagulation factors to such a level that the coagulation process will not be hampered even after the procedure. For the reversible type of coagulopathies, which are inducted by coumarin or anticoagulants which are given to the patients, it may be best to remove the causative agent itself if we can stop it. Then treating the primary illness or defect in order to allow the patient to return to a manageable bleeding risk for the dental treatment period, we can also do that thing in cases of reversible ones. Now, in case of irreversible coagulopathies, if it is present in the patient, The missing of the defective element of that coagulopathy phase or the cascade, it needs to be replaced from an exogenous source so as to allow the control of bleeding. So if there is any coagulation factor deficiency, we have to give a factor concentrate as in case of hemophilia. Now, when medical management is unable to restore the platelet counts to above the level of 50,000, which is required for surgical hemostasis, there is a requirement or need for transfusion of the platelets prior to any dental extraction or any other oral surgical procedures, even if minor. Because if there is bleeding because of the lack of the platelets, there will not be clotting. So there will be deficiency of the platelets to form the clot. So in patients who have received multiple transfusions of these platelets, they become refractory to random donor platelets as a result of alloimmunization. So we will require a single donor apheresis or leukocyte-reduced platelets in such cases which have become refractory. The use of hemostatic measures such as microfibrillator collagen or the antifibrinolytic drugs. It is also utilized and avoidance of aspirin is recommended for 1 to 2 weeks prior to extensive oral surgical procedures, as we all know that aspirin is having an antiplatelet action. When it is having an antiplatelet action, it is usually given in low doses, preferably of 75 milligrams to the cardiac patients so that there is very less chance of intravascular coagulation. So in such cases, when we have a history that the patient is taking aspirin and that too for a long period, we have to stop that aspirin in consultation with the physician of the patient, not without that, because the patient is also very much aware of taking the aspirin. He has been told and what are its effects on the cardiac system. So we will not directly say the patient to stop the aspirin, but in consultation with the physician, we will stop the aspirin for 1 to 2 weeks prior to any extensive oral surgical procedures where we are expecting a lot of bleeding to occur. So when aspirin therapy is in use at the time of minor oral surgery, we can use adjunct local hemostatics even if we do not stop aspirin. When any extensive surgery is done in emergency, what can we do? We can use the desmopressin acetate or vasopressin. It can be used to decrease the aspirin-induced prolongation of the bleeding time or to treat the aspirin-related post-operative oozing. So in case where the patient is taking aspirin but we have to perform an emergency surgery, we will make use of desmopressin. It often eliminates the need for platelet infusion if we are using it in case of emergencies. So the desmopressin is usually available as an injection or a nasal spray for control of the bleeding. Then in cases where the chemotherapy associated oral hemorrhages are produced, the most frequently they are related to thrombocytopenia, and these are best managed by transfusion of HLA matched platelets or FFPs or the fresh frozen plasma, together with topically applied clot promoting agents as adjuncts to these two. And these pictures show the availability of platelets as well as the fresh frozen plasma in the blood banks. They will be available like this and they can be utilized for transfusion into the patient if required. Then in cases of hemophilia A, B, and non-vulnerable disease, what can we do in the dental clinics or what are precautions can we take? The oral surgical procedures, they have the greatest potential for hemorrhage and of all the dental procedures, the surgical procedures, they have more potential for creating more and more blood loss. So appropriate precautionary measures are allowed, they can be taken to allow the surgery to be performed safely. That is a must prerequisite for any surgical procedure if the patient is a known case of a bleeding disorder. So the pre-operative factor levels of at least 40 to 50% of the normal activity, they have been obtained before any surgical procedure that is considered to be normal. So a single bolus infusion, which is used for outpatient treatment, it provides a greater assurance of hemorrhage control in cases which are treated in OPD. We can give a single bolus infusion of the factors. Now, what all things can be utilized in making this patient to be ready for surgery? We can use the factor concentrates, we can use TTAVP or the desmopressin, we can use cryoprecipitates or the fresh frozen plasma, depending on the patient's deficiency state, whatever the patient is deficient in. So these all pictures are for injections of various concentrates and factors which are available in the market to be given in the intravenous form. And this one is the nasal spray of desmopressin, which we have seen before also. In post-surgical bleeding due to fibrinolysis, it commonly starts 3 to 5 days after the surgery, and it can be usually controlled by local measures and the use of antifibrinolytics. The continual oozing from unstable fibrinous clots may require their removal and the repacking of extraction socket with hemostatic agents. Actually, many a times when we pack up the bleeding site or the wound, the surgical wound with the extraction wound, which you must also have experienced in some of the patients, that after removing of that pack, there is still some oozing from the socket. This oozing from the socket may be a delayed oozing in case where fibrinolysis takes place. So in such cases, we advise the patient to repack itself if the patient has gone home and is not able to return back. But if the patient comes back after about 3 to 5 days with the same complaint of oozing, then we have to refresh the area of surgery and then repack it with hemostatic agents to arrest the bleeding process. Only local hemostatic agents and techniques which are available to be applied will include the pressure packing, surgical packs, vasoconstrictors usage, either with LA or without it. Sutures may be placed, surgical stents which can be placed and which are fabricated prior to the surgery and should not cause any irritation to the wound or the site of surgery. Topical thrombin can be placed and the use of absorbable hemostatic materials, which we'll discuss later on just now. Then these hemostatic materials like avitine or helitin, which is a microfibrillar collagen fleece, it aids in hemostasis when placed against the bleeding bony surface of a well-cleansed extraction socket. So it promotes bleeding. It acts by attracting the platelets, causing the release phenomenon to trigger the aggregation of platelets into thrombi in the interstices of the fibrous mass of the clot. So it will promote this aggregation of the platelets in its spongy or microfibrillar interstitial spaces where the platelets which can get aggregated and they will convert into thrombi formation, promoting the clot. Now these pictures show the fleece which is available of avitine and the wool which is produced from this fleece to be injected or packed into the surgical site. Then topical thrombin, which directly converts fibrinogen into the blood, in the blood to fibrin, and is an effective adjunct when applied directly to the wound or carried to the extraction site in a non-acidic medium on oxidized cellulose. So topical thrombin can also be used for the cessation of the bleeding. Surgifoam, which is an absorbable gelatin sponge with intrinsic hemostatic properties. Surgical acrylic stents may be useful if carefully fabricated to avoid traumatic irritation to the surgical site. Yes. Now, surgifoam can be available as tubercles or a strip, which can be utilized for a larger area of the wound and cubicles for extractions of the. Then, in cases where the bleeding has been made or managed for, we can say, for the next 24 to 48 hours, it should not be irritated in any way. So, for the diet, also, we say that diet restriction is to be made to take only liquids for the first 24 to 48 hours so that there should not be any irritation to the surgical site, to the soft tissues surrounding that area, which need this time undisturbed for healing process to take place after the clotting phase, which is followed by After this 48 hours, it can be followed by intake of soft foods for 1 to 2 weeks, which will further protect the clot by reducing the amount of chewing and the resultant soft tissue disturbances. Then the antifibrinolytic drugs which are used, preferably ESCA and the tranexamic acid have been used. They inhibit the fibrinolysis by blocking the conversion of plasminogen to plasmin and resulting in the clot stabilization. So antifibrinolytic drugs, they will cause the clot stabilization. This tranexamic acid 4.8% is available as an oral rinse. It was found to be 10 times more potent than ESA or epsilon aminocaproic acid in preventing the post-extraction bleeding in patients of hemophilia. It's available as a solution or an oral rinse. Now, how to control the pain without any bleeding? Means without inducing any bleeding, how can we control pain? That means without any anesthetic agent, which can be given as a block. If we can utilize the methods of hypnosis, intravenous sedation with diazepam or nitrous oxide oxygen analgesia, which can be used as adjuncts to control anxiety, they can drastically reduce or totally eliminate the need of local anesthesia. But in such cases, I would say that the intravenous sedation with diazepam is also a bit risky procedure where the bleeding tendencies are more in patients. So in such cases, we can put intrapulpal anesthesia, which will be considered safe and effective, following the SS for pulp extirpation. After we make the SS cavity for pulp extirpation, we can put intrapulpal anesthesia. That will anesthetize the pulp in that area and we can do our procedure safely without any pain. Then the periodontal ligament and the gingival papillary injections can be given with little risk when they are delivered slowly and with minimal volume and very little in quantity. So the anesthetic solutions with vasoconstrictors such as epinephrine, they should be used whenever possible. In patients with mild disease, buccal, labial, and the hard palatal infiltrations can be given for the maxillary teeth with a slow injection technique and a local pressure to the injection site for 3 to 4 minutes, meaning thereby after infiltration of the area with injecting the local anesthetic agent very slowly, we will apply pressure with a thumb or cotton pellet for 3 to 4 minutes at that site for the liquid or the anesthetic agent to be absorbed quickly. The block injections, they require a minimal coagulation factor levels of 20 to 30%. So if we are going to give block injections, we should evaluate the coagulation factor levels to be minimum of 20 to 30%. In block injections, a greater risk has occurred or has been seen with the disease, with the severe disease than with the mild one. And when comparing hemophilia A with B, it has been seen more with hemophilia A than with hemophilia B. Then coming to preventive and periodontal therapies, when we see that hyperemic gingiva is present and it is contributing to the spontaneous and induced gingival bleeding, periodontitis has been seen to be a leading cause of tooth morbidity and which causes the extraction of the teeth. The periodontal probing and the supragingival scaling and polishing, it can be done routinely without any evaluation, but with caution. The careful subgingival scaling with fine scalers can be done. It does not need any replacement therapy, but it is careful. The subgingival scaling, usually you will be coming in contact with the gingiva. So fine scalers, when they are used, they should be used very intricately so that you do not injure the soft tissue or the gingiva, which will then bleed. And severely inflamed swollen tissues are best treated initially with chlorhexidine oral rinses and by cross debridement with Cavatron. it's the ultrasonic scalers or the hand scalers, to allow the gingival shrinkage prior to a deep scaling. It has always been advised to remove the gross calculus which is present on the teeth before going to the subgingival areas. Then locally applied pressure and post-treatment antifibrinolytic oral rinses are usually successful in controlling any protracted oozing or in controlling any oozing of blood which is delayed. The periodontal surgical procedures, they warrant the elevating circulating factor levels to the 50% and the use of post-treatment antifibrinolytics. That means if we are planning for any periodontal surgery, we should have the circulating factor levels to approximately 50%, and along with it, we will give the post-treatment antifibrinolytics for the clot stabilization. For restorative and prosthodontic therapy, rubber dam isolation has been said to be done in all the cases of restorative therapies, and this is done to minimize the risk of lacerating the soft tissues and to avoid creating any ecchymosis or hematomas with high-speed evacuators or the saliva ejectors. So dental trauma should be minimized by prompt and careful post-insertion adjustment in cases of prosthetic treatment. In endodontic treatment, often it is the treatment of choice for a patient with severe bleeding disorder. Actually, in cases of severe bleeding disorder, we should be more focused on the conservative and the endodontic management of the teeth rather than the extraction procedures or any surgical procedures. So the instrumentation in such cases should not extend beyond the apex, which can induce bleeding. Epinephrine intrapulpally, when it is injected to the periapical area, it usually is successful in providing hemostasis in that area. Now, pediatric patients, what can we do? If there's prolonged oozing from the exfoliating tooth, the factor concentrates and extraction of the tooth with curettage for patient comfort and hemorrhage control have to be done. Pulpotomies can be performed without any excessive pulpal bleeding, and topical fluoride treatment has also been recommended with the use of patent-fisher sealants in such cases. In orthodontic therapies, as we have been using the bands, brackets, and wires all made of steel and are sharp, so care must be taken to avoid any mucosal laceration by these things. And bleeding from minor cuts, it usually responds to local pressure. It will not need any out of the way management. Now, the patients who are on anticoagulants, it's very important to know history of the patient, history of any medicines which the patient is taking. If that medicine is an anticoagulant agent, the patient will also have a history of any systemic disease which is causing that coagulation process in the in the vessels of the patient. So in such cases, the degree of anticoagulation achieved, it is gauged by the ratio of prothrombin time and the international normalized ratio. Both are taken into account, and then the dental procedure is planned. Now, in this case, the level of thromboembolic risk of the patient is also assessed because there is always a risk. The higher the INRs result in higher bleeding risk from the surgical procedures. So we should not have very high INRs in such patients. Where there is no surgical treatment, an INR of more than 3.5 to 4 without any dose modification of coumarin or anticoagulant is suggested, where there is very little tendency of bleeding from the procedures. Where we are planning certain minor surgical procedures with a little amount of anticipated bleeding, this INR should be less than 3.5 to 4. It may require, in addition to this INR control, it may require the local measures, but the coumarin or the anticoagulant dose modification may not be required. In cases where moderate bleeding is expected, their local measures should be used along with INR reduction to be less than 3.5 to 4. In significant bleeding, where the significant bleeding is anticipated, the local measures are combined with reduction of the anticoagulation to an INR to 2 to 3, or it is less than 2 to 3. So we will, as and when the bleeding is expected, more and more bleeding is expected, we are reducing or we are anticipating the anticoagulation factor in INR, which is assessed by INR, to be reduced more and more. And in cases of extensive flap surgeries or bone extractions, this INR should be less than 1.5, even in cases who are taking anticoagulant drugs. So this is the gauge for the treatment procedure, INR, International Normalized Ratio. So this cormorant's long half-life of 42 hours, it necessitates the reduction of the dose or withdrawal 2 days prior to surgery in order to return to the patient's PT over INR to an acceptable level for surgery. So if we are doing any dose modification of cormorant prior to surgery when we are expecting more bleeding, we should stop this drug for less than, not less than 2 days. That means the drug should be stopped for 2 days prior to surgery because of its long half-life. The use of additional local hemostatic agents such as microfibrillar collagen, oxidized cellulose, or the topical thrombin is recommended for the anticoagulant patients. Then this use of antifibrinolytics may have value in control of oral wound bleeding, thereby alleviating the need to reduce the oral anticoagulant dose. So if we are using antifibrinolytics, the anticoagulant dose reduction may be there. Then the shorter anticoagulant heparin, which is utilized in some cases, it is administered by the intravenous or subcutaneous route. In oral surgical procedures, which can be carried out without a great risk of hemorrhage when the local hemostatics are used in patients who are receiving heparin subcutaneously, so there is not much risk for hemorrhage. But if bleeding emergency arises, the action of heparin, it can be reversed by giving protamine sulfate, which is an antagonist of heparin. Now, with this, we can summarize the whole chapter or the whole lecture as we have studied the various phases of coagulation, various tests in the laboratory which can be advised to see various phases in the deficiency of various factors in the coagulation cascade. Then we can see clinically what type of bleeding is occurring to check whether the bleeding is from a defect from the vascular phase, from the platelet phase, or from the coagulation phase, or in the fibrinolytic phase. Then we have seen the various findings in the intraoral area on the mucosa and over the skin in the head and neck area. We also have seen the various dental management or how can we manage the patient who has a bleeding tendency repeatedly and in which the patient's bleeding is the management is done in an emergency. What are medicines we can utilize? Then we'll be formulating a questionnaire and giving to you to be filled up and submitted in due time, which will be given to you. And that questionnaire will be based on the second part of this as an assignment given to you. And for any queries, you can contact me as at my official mail ID, dr.saurabh2002@bbdu.ac.in. And thank you for your patient listening. Thank you.